Thank you very much for your insights. I think I'll start with Dr. Eliana. I've got a few questions for the panel, but I'll just direct one question to you and then on to Dr. Ida. The first thing I'd like to ask is, speaking with Jonathan from Kelsis, speaking with a number of breast cancer NGOs, they have reported on the ground that breast cancer is being seen at earlier stages than before. Do you see that happening on field data at present? Because that's what we're hearing. Just want to get a sense. Is it true? I mean, if true, is it going to be the trend in the next 5 years that we can see? The second thing, in terms of lung health initiative, what would you feel would be some quick wins to address the prevalence of waste consumption, especially in schools, amongst secondary schools, which is now a big thing? What would you think would be a good win to address that, given that prevention is always better than a cure, especially what vapes could do? To Dr. Ida, I understand we can see that there's a real need for colonoscopies, but how would we create more colorectal surgeons? Because if you look at the list available, it's in the small hundreds. And how do we increase capacity given the need for it? As we are an aging population and colorectal cancer is seen amongst people beyond the age of 55 and even into the 70s. Those questions, please.
Right, thank you so much for the question. So if we look at the data for breast cancer, we still have more than 50% at stage 3 and 4. But if you compare to other cancers, so it is actually doing really good. So meaning that you still have 40+% that is coming at stage 1 and 2, which is almost half. So probably if we compare, this is from 2017 to 2021, but if you compare from 2007 up until 2016, so there is a shift towards, because if we look at a small percentage of increase in stage 1 and 2, that is also good. Coming from stage 3 to stage 2, that is also good. So meaning that breast cancer has been in the policy for, I think, a long time. So probably it requires a lot of effort on awareness, and I know there are so many NGOs on. We have more than 20 NGOs actually for cancer alone, and we have so many on breast cancer. We have from survivors, we have the professionals, we have the patients, and even the advocates alone in the NGO. So they are doing so many things, and I think it is giving an impact, because we cannot see the impact within probably not even within 5 years of time if you want to see on downstaging. So that is our aim. Our aim is actually, of course, we have not reached the target that we set from 2017 in our National Cancer Control to achieve by, but the target is to be achieved by 2030. So we hope that we are in the progress of achieving it by 2030. So, but that's why I always emphasize, and I always share, if I got the chance to share with other countries, that we are so privileged to have all these NGOs on cancer, and that's why we are getting them to strategically work with us in our framework for cancer control, so that what they are doing will have more impact in terms of our outcome for cancer, especially downstaging. Downstaging is very important, then only you can talk about survival and of course premature death. Second, on the lung health initiative, yes, that is what is unique about this lung health initiative, because we emphasize, we be very specific on what we do in terms of promotion and prevention. So in terms of prevention, we look at 3 risk factors: smoking, occupational exposures, and environmental exposures. And for smoking, we have the new Act 852, the new Act on tobacco control and smoking products and tobacco control. So school is one of the setting that is within the prevention activities. And we just had a Back to Cinema program where we call all these school children to watch movies with us. Of course, with Agent Ali. Before that, what we want to show, not Agent Ali, but we want to show the movie on, the short movie on the Black Mark, if you have noticed it on the news, that talks about vape. What the effect of vape actually. If you look at the movie, when I first watched it, I don't get what it means, but actually, it actually talks about what will you experience when you take the vape, yeah, and how a small children choose vape over milk bottles. So that is one of the very specific. That's why we want to be very precise and specific, which target population and what would be the activities. So this and smoking, as yes, we are trying to get that ongoing. I think we have a specific team looking at that. We have a specific team looking at occupational, yes, and we also have a specific team looking at environment. So that is to strengthen the promotion and prevention part in terms of lung initiative.
Thank you for your question. So I think that is a very real problem. So the issue in the medical profession is that, well, among gastroenterologists and surgeons, is that 80% are in private, and that number just is increasing all the time. I think we had about, if I was not mistaken, among my KKM colleagues, 8 consultants just left in a pool of maybe 30 in the Ministry of Health. So just to tell you how terrible the situation really is. So that requires governmental intervention that perhaps is beyond my capability. But I would say that, and so what happens is, it's not that you can't get a colonoscopy, it's just going to cost you 5,000 ringgit if you're not insured. So where does that leave the B40? Where does that leave the M40? And I think this is the real issue. It's not about you can't get colonoscopies. If you went to, I don't want to say Sunway, but anywhere that's a private hospital, you're going to get your colonoscopy tomorrow. But what happens to the underserved population? And I think this is the problem. Because yes, you cannot blame doctors, you cannot blame the Ministry of Health hospitals. They are inundated with patients. They don't have the capacity or the capability. It's very, very tough. So I think, I'm afraid, it's a lot of things we simply cannot do. So I think that the thing is, for MSGH, at least, the Malaysian Society of Gastroenterology, this is what I was speaking to Dr. Morali, who's MD for National Cancer, is that what can we do? Because we can scope, that we can do. So things like offering up a mobile colonoscopy service is something that we want to do, where, if, again, Dr. Liana says, okay, these are the places that offer FIT positives. If you've got enough, if you've got the FIT positive and there's a long waiting list, then we can try to do these cases, And I think that one you will get the private doctors to come in as part of their, social corporate responsibility and all that. I've looked into trying whether or not we could get the private hospitals to give as part of their CSR free colonoscopies for B40 and all that. As far as I know, the feeling that I get on the ground is they don't want to. Yeah, I'm quite clear on this, because they say they can't afford it. They can't afford it.
Prof?
Yeah.
Prof,
how about the government outsourcing to private hospital? Like in Australia, they do that, like they, say this private hospital will have, we will pay 30 colonoscopy a month coming.
Well, let me just ask Liana, is that feasible?
Yeah, we had a discussion with Prof. Ida and our colonoscopy team, colorectal team, sorry. Outsourcing is one way. Mapping out the distribution is another thing. and co-payment is another way, of course. So these are all among the options that we are discussing, and to see which one is better for all the populations, because right now we don't outsource. Okay, so at the moment we cannot really say. Of course, the colonoscopy services are there, and it's overwhelmed because on top of screening, those are for positive, but they are also doing surveillance. Okay, so these are among the things. But of course, the healthcare coordination, the whole system needs to be reviewed as well. Colorectal screening program has also been there for more than 10 years. And we are actually have evaluated the whole program, and have came out with suggestions and to improve, and of course outsourcing is one of the options. We are exploring also in terms of looking back at the distribution of all the colonoscopy services to map out with where does all the screenings and positive are coming from, so that they have the proper way. The navigation will take place to make sure that no one is being used from the definitive screening and diagnosis. So this is also I must say that we have not reached the goal of early detection, because they are still coming in late, because colorectal and cervical cancer has a precancerous lesion where we can intervene early, so that we don't have high incidence of cases, or we need them to come in early detection for early prompt treatment. So we have not reached that. We are in the process of evaluating, not in the process, but we are coming out with a new plan.
I think one of the things that the Philippines does, which is very radical, I know, is actually that governmental policies actually force private doctors. Most of them are in private. I don't know if you've looked at that. You know, they actually have to do sessions. They're actually forced to do sessions, you know, in government as part of because the payment is very poor there, one can imagine, you know, and government is seen more like very few people actually stay. They sort of are forced to do these governmental sessions, you know, it can be done, but these require cabinet level, huge decisions. I think very practically on the ground, I agree with you. So for example, Putrajaya, we were talking about this, Putrajaya might not have a big catchment area compared to maybe Klang, so screening can be directed there. But it will come up with its own issues. People in the B40 group, maybe to go from Klang to Putrajaya is expensive, so they won't do it. You know, and that's where NGOs could come in. NGOs could say, okay, I'm going to transfer you at Rakanku or whatever. You know, so you can find this navigation pathway. So that's step one, I think, within the government system. And then, as I said before, private-public cooperation, like outsourcing, I don't know. But from our perspective, I think if like Malaysian Society or Colorectal Cancer Society can actually provide services for colonoscopy, I think that's one option. These are very short-term measures. The long-term ones, the ones that probably make big difference, is going to take a long time. And big policies, which have not moved in 20 years that have been back, so I don't know.
Dr. Eliana, just a quick one. In Australia, they actually, because a lot of people still miss to do the regular FOBT, 50 to 75, too early. In Australia, actually, they mail it out. Is that an option to do in Malaysia? Mailing the FOBT.
That is population-based. So when we do screening, you can either do population-based or opportunistic, which what we are doing now. So it's very much depends on the resources, highly dependent on the resources and our capability in our country, because it requires, first is the medical record. You need to have a very strong system so that you can get all these people to be notified through emails, through phones, so that once they reach a certain age, you will get notification on your phone, on your mail, saying that you need to go for the screening, and if you don't come, then they will follow up on you. So that requires extensively on a very good system, which we do not have, but we are going towards our electronic health records, one record for one patient, which the planning division and the health transformation office is looking at. So that would be the future where we want to, our aim to be. That will be very great. You will not miss out on anyone, but it requires a system of financial resources and a strong healthcare system to be able to cope with the number of populations, so that our planning, the screening will target on all the populations. But now we are targeting on high-risk group, on opportunistic, where we can catch them, so we ask them to go. So that is one step behind the population risk. So high-income country, middle-income country, that also plays a very much role.
Thank you. Any more questions in the audience? Yep. Up there, please.
I think it's been loud.
Okay, thank you.
Dr. Eliana and all our panels, because screening, as what Data mentioned, is for asymptomatic. But most of the cases that comes into the service, it comes when they are 6 years before at the hospital. So is there anything that can be done to detect it earlier at the primary care level?
Okay, that will be the ultimate goal, aim for doing screening and early detection. So screening is, of course, among asymptomatic, but they have certain criteria to meet. If we go for population-based, and only age would be the criteria. But opportunistic, we need certain criteria to meet, because of we need to also be realistic looking at our resources. Early detection is actually for those who are symptomatic, but we want to catch them early. So that is why it is something that we are looking at in our lung health initiative. We have asymptomatic or high-risk group screening, but we're also looking at those with symptoms, but we want to early detect them, early diagnose them with, for example, lung cancer, and how we do that. So that's why instead, if we want to put low-dose CT, that is not going to happen in clinic kesihatan in our healthcare facilities. So that's why we put on X-ray. But X-ray doesn't help in terms of lung cancer, very specific to lung cancer. So that's why we try to embed on AI assisted. So with AI assisted, you are asymptomatic or you are symptomatic, high risk. AI X-ray shows something, then that immediately we want to intervene on you. Or if AI X-ray is normal, there's nothing, you're symptomatic, you're high risk, but we know that we do not want to miss on this, so that's why we establish this referral pathway, so that you will not be missed. You will straight go to low-dose CT, you will straight be referred to a respiratory physician. So that is the pathway that we want to see in terms of early detection. Early detection meaning that you are already symptomatic, yes, but we want to diagnose you at stage 1, stage 2, not at stage 3 or 4. Especially lung cancer, because lung cancer is lethal, but is very aggressive, but diagnosing it even at stage 2 is considered early. So that is what we want to see. That's why the aim of early detection and screening is to downstage the cancer, not to improve outcome, improve mortality or survival, but to downstage the cancer.
I think very simply from a colorectal cancer perspective, I think that is why primary care does play a very important role, because I told you constipation is common in the population, and you could argue that most people are not going to have colon cancer. So the primary care education is very important. I think that's something that we could target. But I think if you ask me, FIT is not just for like polyps; it's also for early cancers. So I think FIT is probably now still the cost-effective way of doing it. The problem, because it's not 100% sensitive and specific, you are going to miss some pieces. They are going to overdiagnose. You will be some cases where they don't have cancer, but I think if they fall in the good age group, 50 and above, especially with some additional risk factors, actually any age group, then I think FIT, in my opinion, at primary care is a good initiative. I think it's not that expensive anymore, right? Yeah. So I think, I think for colon cancer, that's a good first line still.
Any more questions from the floor? Yes.
Hi, thank you panel speakers. I enjoyed the talk a lot. I'm Dennis. I'm a public health physician from Singapore Cancer Society. Just wanted to check on if there's any progress in terms of using full blood count or complete blood count and algorithm to do early colorectal cancer screening or detection. That's in the US. They have started to launch it already, and I think there were some that were FDA approved already. It is something that is really new in Singapore. We are just taking a look at that. So I'm just wondering if there was any views about that.
Sorry, full blood count? Sorry?
Using full blood count to actually detect.
Right, hemoglobin levels and all this. Is that what you mean?
That's right. The complete blood count.
No, I don't know. Is that what they're doing at in
US?
In
yeah,
US,
the LGI flag.
Right. Not as far as I know.
Okay.
Yeah. Is
Thank
that
you.
what they're planning to do in Singapore? Or?
No, it's something that it was brought into Singapore, and we have been alerted about it. I'm just wondering that if it's.
And what do they find, that it's cost effective to do that as a screen, as opposed to FIP?
It's actually undergoing review based on our population currently. Yeah, I think it's with the Health Sciences Authority. Yeah, thank you.
Thanks. Yeah, no, as far as I know.
I think that the full blood counting is actually using an AI-driven calculation to assess this one. I assessed it actually. There was one application at the MOSTI level. They applied for grant for that. So I'm not sure whether it has passed through, but I've seen the application for that.
It's a very good idea, I think, right? Because most people at least probably would have their full blood count. Yeah. I'm not aware of it.
Any more questions? I have a question for Dr. Bunong. With that question. So we know dense breast increased risk for breast cancer, right? But most of us will know that we have dense breast after we've done our first mammogram, which is 40. And by that time, it's a bit too late to change, to have kids, to start breastfeeding and things like that, right? So as someone at 40, 45, when they did their mammogram and found out that they have dense breast, what sort of advice in terms of what they can do to overall reduce their breast risk factors, breast cancer risk, and also in terms of screening, what should we advise patients, friends,
I think the current breast cancer guideline is every 2 years. So the guideline is as 50, but I think when we look at the trend now, more younger women are actually getting diagnosed. They think the threshold is 40, but I think I'm seeing it at 35 itself. So our plan is actually to find out which is the right age to start. We should not follow what was already implemented in the Western where they start at 50. The target should be somewhere between 35 to 40. Again, the question is whether it's cost effectiveness of running a nationwide screening is a big issue. So one thing that we are doing at Cancer Research Malaysia is also to come up with a decision modeling. To come up with, we want to make sure every woman has the chance to get screened, but we're going to do like a risk stratified screening. Again, it is in a concept of high risk group, but we're going to do it more systematically using modeling system. So that's one thing. So what if you go through a mammogram and you got to know that, okay, let's say you go at the age of 40 and your first mammogram and you know that you have a dense breast. Okay, again, I'm not sure many of you are aware, mammogram, having a dense mammogram is not just because of environment or how you live your life, it's also heritable. So if your family members have a dense breast, it's likely your kids and whoever's relevant to you or related is also going to have dense breast. It's about 50 to 60% is heritable. But again, it's not entirely about genetics. So 40% or 50% is still somewhere that you can, there's a space where you can actually reduce a mammogram. But there's no, there's no valid evidence to say that if you do this, you're going to reduce your breast density. Again, if I go back to the factors that I mentioned, mammogram is one top, so which means one of the primary target when you do screening is going to be through mammogram screening. While the other two modifiable that I've mentioned when it comes to Asian setting is BMI, and the second one is passive smoking. Smoking is again back to campaign when it comes to smoking, putting bans on this, on tobacco and so forth. But when it comes to BMI, the question is, if I say I have a high BMI, what's the next thought in your mind? You should. Yes, your diet, your physical activity. It goes back to that lifestyle. To what extent this is going to reduce, I'm not sure, but it's not about just today I'm doing it and then the next day I'm not doing it. So it has to be a consistent effort to actually see an impact. So again, if you're going to reduce breast density in a sensible way, I would say your lifestyle. And of course, screening. So now the problem now in Malaysia is if you have opportunistic, it's not reaching out every part of the population. That's one issue. Number two, even if it's reach out, let's say they go for the first screening, what is the adherence rate? They're going to come back again for the second screening. This is one thing we have. So to accommodate this, we are coming out with risk assessment tool. Not risk assessment, risk communication tool. To help people understand what does that mean if you have a dense breast. What does that mean if you have a high risk? What should I do? Now, I have this report, what I should do. So this is a very important tool that we need in order to communicate with someone who's not from a scientific background or not from a professional, not from a healthcare setting. That's one. Screening, yes, cost-effective screening in place. And I think PNP works very important. I think it's not just about early detection. Once you detect, timely treatment is very important. So the period from the point that you are presented to diagnose and until you receive your first treatment, the time is very important. It's like ticking time bomb. If you don't get it from the right time frame, you eventually get diagnosed at a very late stage. Again, the question is, treatment is going to get expensive. It's harder to treat, so it's poorer prognosis. So lifestyle. Back to lifestyle. To what extent, I'm not sure, but then that's one way to go for it. Screening, adherence rate is very important.
Thank you. Thank you. Any final questions here?
Good morning. My name is Loretta. My question goes to Dr. Ange. So it's a very simple question. My parents are Asian, but I was born and I am currently living in a European country, France. So you were comparing European and Asian lifestyles and data. Did you look into the perspective of Asian people living in European or American countries? Because there is a lot of people. Thank you.
Yeah, I had this question earlier, even in previous audience. So we did have we did look into Asian, not just in Asian countries, but also those in the West countries. When we compare in terms of lifestyle, I'm pretty sure there's a change. You're going to adapt to the surroundings in that. Even if you go for just 1 month in UK, you're going to live in their lifestyle in the way that the food that they eat, what is accessible to you in that area, and that things that you do also changes according to the weather there, right? That's one. Lifestyle is definitely there's a change. Genetically, we are pretty much similar because we are brought down from ancestry. But the second question is not exactly similar because there's some mixed marriage happening even in not just in Malaysia or in within country, also in abroad. So genetically, there's a differences that we may need to take into consideration, but I believe lifestyle is still different. in terms of impact-wise. And again, it backs to whether you practice this or not. If you are a smoker, if you're not a smoker in a Western country, then likely that is not a relevant risk factor in your case. So it goes back to what is your practice. But I believe if you Asian in a Western country or Asian country, there is a change in lifestyle, but there's a comparatively similar genetic factors.
Thank you. Any more questions? All right. So, if there's no more question, I would like to ask our panelists if there's any final comments. Professor, Dr. Eliana, Dr. Boon Hong. No. So I think it's almost 10:30 now. Then we all can go for our coffee break. What time should we get back here? Okay, yeah, there you go. So 11:30 now, you can go for your coffee break and then make sure you come back at 11 o'clock. We're going to have abstracts, rapid fire presentations. And that will be a really fun one, okay? So thank you so much to our panelists. Thank you. Give them a round of applause.
But before the